Good morning, good afternoon, or good evening to everybody. It's a pleasure for us to be here. The work that we present has been developed in the computer science department of the Catholic University, Uruguay, in the applied intelligence system. We work on artificial intelligence applied to different contexts, in particular, clinical medical doctor is a pediatric emergency unit, and the pediatric emergency room of a private care provider. She has helped us for years as a field expert in various clinical decision support systems research projects. Juan Francisco Cruz and Lucas Lois are software engineers who graduated from the Catholic University of Uruguay, where they work as assistant professors in artificial intelligence and computer science courses. Both are active researchers on artificial intelligence, currently focused on the application of Bayesian Networks and deep learning to clinical decision support and natural language processing or named entities recognition in electronic health records. In the professional field, Juan Francisco works as a machine learning engineer at an AI software company that's called Trio Labs, and Lucas works as software team leader at December Labs. I am Ernesto Ocampo, software engineer and computer science PhD, and I am a full-time professor at computer science department, where I teach subjects such as artificial intelligence, machine learning, and algorithms. My research focus is on applied artificial intelligence, and I have also worked in the software industry for many years. We are going to present a work that started as a case study in our artificial intelligence course in the informatics engineering career, and which was later extended and published at the IEEE Eurocon 2021 conference. The study was conducted mostly in the second and third quarters of 2021, and in general with pre-COVID-19 vaccination situation. At the season that was considered a high prevalence of respiratory diseases is common in our country, and at the same time, we were facing the peak of the COVID-19 pandemic. I will now ask Dr. Herrera to explain us the medical context about respiratory diseases and their differential diagnosis during the COVID-19 pandemic.
Good morning and good afternoon to everyone. The priority was to diagnose and treat COVID-19. So every person who had a respiratory symptoms or anosmia had COVID unless the contrary could be demonstrated. So it was in this complex scene, doctors had to work, trying very hard not to make fatal errors, trying to keep in mind that although an illness looked like COVID, it could perfectly be something else. It was very difficult to decide which were the best ways of helping a patient, and knowing that sometimes there is a very thin line that separates risk from benefit. It is precisely in this kind of scene that the clinical decision support systems are a very important tool to assist physicians in the complicated and difficult decision-making processes that they have to face every day in the virtual as in the personal care of patients. The main difficulties of the virtual medicine those times were, on one hand, deciding which patients deserved personal attention in the emergency room, and on the other hand, making the differential diagnosis based on the patient's symptoms. Just some weeks after the onset of the pandemic, it was clear that COVID-19 produced a wide range of symptoms and combination of symptoms, many of which were in common with other respiratory diseases, such as cough, sore throat, or headache. Some patients had fever, while others didn't. Some patients had only anosmia and dysgeusia. Others had no symptoms at all, while the minority of them had severe clinical manifestations like inflammatory syndrome or pneumonitis. Ordering a PCR test for diagnosis of COVID in our country was easy, but getting the results could take at least 2 or 3 days. Meanwhile, it was important to make a correct diagnosis and differential diagnosis in order to start the treatment without delay especially in those patients with potential severe illness. The differential diagnosis considered in this research, the virally infected common cold and influenza, which have a clear seasonal peak in autumn and have many symptoms in common with cold. Bacterial pneumonia, which is an infection of the lung tissue produced by bacteria, tuberculosis of the lungs, which is the infection caused by a bacteria called Bacillus, and presents as a subacute disease characterized by low fever and cough, lung cancer, which may present with cough. And finally, the tumors of the skull base, which can present with anosmia, a typical symptom of COVID-19. Asthma, which is an allergic respiratory disease characterized by crisis of bronchospasm, has been considered in our system not as a differential diagnosis, but as a risk factor for complicated respiratory infections, including cold. Before ending, I would like to give you a pair of examples of real differential diagnosis of COVID-19 where counting on a CDSS could have been. The first one is lung tuberculosis, which is an infection of the lung tissue caused by the Bacillus. Before, its clinical manifestations are fever, cough, and in the severe cases, this may have the X-rays and shows null pathologic images, and in some cases, early fusion. It requires a prompt treatment, specific antibiotics, but not other medications used in COVID pneumonitis like steroids. You have a clinical case of a patient with tuberculosis. Another rare differential diagnosis is the skull-based tumor that presents with anosmia. During the early stages of the COVID-19 pandemic, anosmia was very frequent, and often it was the only symptom. While waiting for the PCR result, it was important to take this affection into account in order not to miss the opportunity of making an early diagnosis and refer the patient to neurosurgery as soon as possible. We will show later how the Bayesian network would help the physician with this diagnosis. I will now pass the floor to who will start describing the network.
Thanks for that. By following knowledge from different expert sources and expert knowledge, the network was created by assembling variables in 4 different categories along with their relationships. Our network is able to model multiple different conditions in a differential diagnosis, modeling them with risk factors which affect their probability. Apart from those, other nodes are responsible for modeling symptoms like dry cough, clinical evidence, which includes lab and imaging studies. Both the particular variables used and the relationship between them were selected and decided upon based on a wide base of expert knowledge derived from consults, published research. When it comes to differential diagnosis, the context in which this work was developed focuses on respiratory diseases and others with similar symptomatology, including, of course, COVID-19 itself, but identifying 8 conditions in total. These include respiratory illnesses, of which pneumonia, COVID, other causes, influenza, COVID-19 itself, and common cold. However, due to overlapping symptomatology, conditions in a separate category were selected alongside it. Those were skull-based tumors and lung cancer and tuberculosis. It's one of the main data points to get from an incoming patient. Symptoms are a fundamental part of the network, but they can be measured the moment the patient comes into the clinic. Most of them are related, consequent, of course, to multiple of the identified conditions. The identified symptoms were varied in the region of effect, their severity, and identifiability. And they include dysgeusia, which is, of course, loss of taste, fever, dry cough, vascular cyst symptoms, hemoptysis, headaches, anosmia, chest pain, fatigue, dyspnea, renal failure, and myalgia. After these symptoms are examined, more information is likely to be necessary in order to arrive at the definitive diagnosis. Multiple tests are likely to be required, each adding or subtracting to the likelihood of each of the possible conditions, none of them, of course, being able to provide 100% assurance of the result, particularly in this context. And we are speaking here about discrete nodes, depending on positive or negative result for each given test. Tests in this case, again, vary, include stuff like PCR tests for COVID-RT, COVID antigen test, and then scans such as the chest CT scans, chest RX, head CT scans, animal tests such as influenza antigens, abnormal hemograms, or even a CMR microscope. Finally, either permanent or acute risk factors can be a very good differentiator between the conditions, as a way to select them between conditions that share previously identified symptomatology and the test results. Many of the risk factors in this case are positive in their influence. This could be having had a COVID contact, being a smoker, having trouble to account with a high presence of either COVID or separately tuberculosis, or suffering from immunodeficiency, or again, separately suffering from asthma. Others, however, and no less relevant, of course, offer a negative impact on their related condition. And these are having been vaccinated, either against influenza, COVID-19. Now, Juan will continue addressing knowledge engineering challenge we have encountered this.
Hello, everyone. Let's talk about how to build a network like this. The first thing that we think of is to find a dataset that holds all the information required to do. What we want here is a clinical database that has relationships between diseases, symptoms, and patients. Finding a public database like this is highly unlikely, as most of this information is not complete. With this, I mean that it does not include all the variables we intend to use in our network. Other problems could be that there is a lot of work to be done on the data itself to make it available to use, such as protecting the anonymity of patients. Knowing this, we decided to look up for expert knowledge, extracting prevalences and statistics from medical academic research and official organization publications. This is not an easy task, as there are a lot of publications out there, and most of them have different results. So we have to analyze carefully and decide which ones to pick that suit the scope of the network we are going to build. Our final work had around 68 sources of information, coming from the National Library of Medicine, the CDC, the NHS, and many others. From those, we extracted around 126 parameters to build the network and its relations. All this information was validated by experts in the field using simulated cases of what they saw in reality. Some of the problems we found, some of the issues we found when seeking information are: the first one is about non-specific numbers. So publications do not present specific numbers. For example, they use ranges of numbers, and we have to decide which ones to pick or what to do with them. Other papers directly do not use numbers, and instead they use words such as: most cases of this disease present fever, and we have to see what to do with that information. Another problem is hidden information. Some information is hard to find as it is not commonly published. So in some cases, you have to do calculations and estimations with extra information, such as, for example, getting the amount of people that live in a region and using the information we have in the screen of how many people in that region were vaccinated. With that, we can get the prevalence of being vaccinated. And the final issue we saw was that we had data difference and different wording for variables. Most of variables can have synonyms or different ways of appearing in publications. We have to check whether they are referring to the same as our variables or not. We can see this example between weakness and fatigue. And on the other side, in these two images, we can see that headaches, for example, have different values in each publication. Both publications refer to the same study about brain tumors and symptoms. Now, Ernesto will show us how the TDSS could be used to address one of the example cases described earlier.
Okay, let's see now how the physician could use the network as support for diagnosing the tumor example case that Dr. Herrera described earlier. This was about male patients with no underlying conditions that declare anosmia, no other symptoms, no traveling abroad, nor being in contact with people with COVID-19, and the physical exam was normal. So the step one was to register this positive and negative clinical data in the network. And once run, the system shows that the most likely diagnosis is just cold. Focus on this, just cold. But all we see that the lung cancer and skull-based tumor had a low but existing probability of around 1%. As a second step, given the epidemiological situation and the frequent association between anosmia and COVID, an RT-PCR test was ordered and performed. The result could be available in 48 hours or even later. While the physician waited for the result, he used the network to simulate different scenarios and evaluate what could be the outcomes if any of the medical procedures or imaging studies show positive results. We must remember that in the referred pandemic scenario, this type of imaging study was very limited and had to be highly justified. Simulating a positive X-ray, we observed that the chances of lung cancer substantially increase. COVID pneumonia probability also increases, but not significantly, due to the absence of other related symptoms. If the PCR tests were positive, the patient most probably has COVID, but we will also observe the chances of lung cancer to be high. If negative, COVID options could be ruled out. In any case, a chest X-ray should then be asked for and indicated as a first step. If the X-ray were negative, she would still have to analyze the situation regarding the skull-based tumor. She then simulates a head CT scan. If it were positive, the probability of a tumor would be very high, regardless of the result of the PCR. It was enough to request the limited CT scan. Finally, the PCR test was negative for this case, and given a negative COVID test with a history of 2 weeks of an intracranial tumor should be ruled out, and so there is enough evidence to justify ordering a head CT scan, even when these procedures were highly limited during the pandemic peak. Okay, then just a few conclusions and remarks. During the pandemic, the first line of medical diagnosis of respiratory diseases and other related to them was highly affected, introducing an undesired bias towards COVID-19. Bayesian Networks offer several unique features that are very valuable for physicians. They have the ability to simulate different procedures and possible outcomes. If using diagnosis mode often helps to identify most cost-effective next steps to select what next studies or lab exams to indicate. It can give warnings about biases diagnosis. They are fully explainable, something that is very valuable for physicians, and can be used also for simulation and training, which can be very valuable in context with scarce experienced practitioners. The most challenging and time-consuming task remains to be the knowledge engineering of the Bayesian network. For such varied entities, the data sources are very numerous, heterogeneous, and of different quality degrees. As future work for this application, we continue working on the network and will try to use new or updated data sets that are becoming more and more available after the pandemic to automatically learn subnets and improve global net quality, integrating data from additional diverse sources. We know from the bibliography and the many examples that Bayesian networks are very tolerant to parameter variations. We plan to develop a sensitivity analysis to better understand how the probabilities margins of different variables affect the global net performance. In this very conference, we have seen examples of dynamic Bayesian networks applied to chronic diseases control. We will explore the suitability of using such kind of networks to represent the diagnosis protocol stages. And we are working on developing and deploying a mobile front-end for field specialists. This year, we are working on a subject that we have addressed for several years using other AI techniques, that is diagnosis of acute bacterial meningitis. This is a mandatory report disease as per World Health Organization. Although the global prevalence of meningitis has substantially diminished in the last 20 years or so due to the start of vaccination, it is still a very serious illness that produces very bad consequences, particularly in children. It is endemic in several regions of the world, and maybe you have seen that recently there was also an outbreak in Florida. Our research is focused in babies from 0 to 1 year, mainly because the clinical part of the diagnosis procedure is more critical for them. Again, in this project, the Bayesian network design and knowledge engineering is very challenging, similar to the situation with the presented work and with other cases presented in this conference. There is no raw clinical data available to be used for automatic or hybrid network learning, or the data is very heterogeneous. Structured design is being done by experts' knowledge elicitation and bibliography review, and the parameters have mostly been elicited by a huge bibliography review and several rounds of tests and tuning by medical experts. In most cases, it is difficult to find quantitative data. This is just a picture of how it looks. The complete current network, as it is basically a BN2O network with 57 target variables, 57 variables, 9 of them are the targets, differential diagnostics, and more than 270 relations. Using submodels, it is a bit easier for the experts, physicians, to see the way they usually perform the diagnosis procedure. First phase in the emergency room, there is a clinical exam, physical exams, and then there are other more detailed tests that take more time or are more risky, like cerebrospinal fluid and blood tests, secondary stages to deepen the differential diagnosis. That's just an example. Okay, thank you very much, and we are now open for questions.